A person who's done a huge amount of heavy lifting in working on creating medical homes within the state of Alabama is Dr. Tom Howard, who's our keynote speaker today. Dr. Howard's a professor of pediatrics at University of Alabama in Birmingham, which is one of the largest sickle cell centers in the country. He's in pediatric hematology oncology, previous director of that division. He's incredibly well educated and well trained, completing his medical school, pediatrics and pediatric hematology oncology training at the Johns Hopkins University. Earlier in his career, he had mostly focused on basic science and had much success in the laboratory focusing on white blood cells, but that's not why we asked him here today. Over his career, he juggled the responsibilities of running a basic science lab while providing medical care to children and young adults with sickle cell disease. And for this presentation, we asked that Dr. Howard share his experience that he has in building a network of providers, clinics, and caregivers who are committed to serving individuals with sickle cell disease. Without dating Tom, he's spent over 30 to 40 years caring for children and some adults with this disease. He's been recognized for his hard work by many awards from the NIH, HRSA, and foundations to develop this network, as well as his work. And he's been a mentor and generous teacher to several trainees, colleagues, and families. And I'm sure that he'll be able to claim that he's mentored the rest of us after giving this talk this morning. So thank you, Dr. Howard, for agreeing to come and give us this talk. And let's all give Tom a warm welcome.
I feel like a bit of a preacher here. I'll put this down, that comes into play a little bit later. And I'm going to probably step away from the microphone, but can you hear my voice well? I mean, I project extremely very well. So, thank you very much, Allison, for inviting me, and thank you for forcing me for the first time in 24 years of working in this area, really look at what has evolved and how it evolved. And I think there are some lessons within that, which I hope that I'll be able to convey to you. Now, first of all, let me enter a disclaimer, and that disclaimer is, I don't know the first thing about medical homes. I only know what I did. Medical homes came along as a concept in the late 60s, early 70s, but I really didn't apply that. What we just did is work a little bit along over time and try to get people, primary care physicians that support them and families that support them in integrating themselves into a coordinated system of care. So a lot of my comments about barriers and pitfalls are going to come in the last 2 to 3 slides. So if you want to go to sleep until then, but they won't make any sense unless you follow through the rest. Okay, so medical home for patients with sickle cell disease includes the coordination and integration of a large number of people in the community and in comprehensive sickle cell centers. In Alabama, we have a very large state, a large rural population, and we serve patients out of 62 of Alabama's 67 counties. And the challenge has been, how do you get services to people, and how do you help support a medical home, not just in the city, but also in the outreach areas. This is the focus, though, of everything that we've done. Now, the characteristic of a medical home, and this is my only slide about medical homes, I'm counting on the other people to tell you more about those. But, you know, it's a coordinated care system driven by a personal physician who has a relationship with the patient ongoing. In sickle cell disease, that's important. He directs his medical practice, and that's in the biggest sense. His medical practice would include the people in his office, the people in his community, and such. And I would like to create the notion that it also includes those of us who are in comprehensive care in university centers. It's oriented to the whole person, critically important of all stages of life. In a chronic disease like sickle cell disease, where repeated episodes of hospitalization for a variety of complications, pain, crisis, pneumonias, stroke, if that becomes a problem for you, ultimately a vascular necrosis, renal disease in an older age. It spans a lifetime in terms of impact on felt people. And it's very difficult to deal with because many of the demands are episodic. So we have patients who flip in and out of our system. They'll be gone for 2-3 years, and then all of a sudden they reappear. And that's, I've learned to just roll with the punches on that. And then there are the persons who really remain involved. The critical thing is that the care is coordinated and integrated so that primary care provider who forms the medical home is the person who initiates and integrates the patient's care within the large system of medical care. And finally, that quality and safety are hallmarks. Quality means that we're practicing evidence-based medicine, that we're applying the best knowledge, the most current. And I would add to that, I think, since we're in a research university, that we're also adding to the knowledge of how to take care of sickle cell disease simultaneously. And there's enhanced access to care. Now, you know, if you read HRSA's website, which I copied this off of, that says extended hours clinic. You know, I don't think that really means enhanced access to care. Means in sickle cell disease access to some specialty, access to vocational rehabilitation, access to educational consultants, truly psychosocial support, truly global kind of access to care. And then there's the issue of payment, and that holds us all by the protocol. On Tuesday in Alabama, we're going to have a referendum on Medicaid, and fundamentally, if that goes south, it threatens everything that we've done now in 24 years. And that's how fragile this is, because the majority, many of the patients in Alabama, 62%, that are in the network I'm going to describe to you, have as their primary funding Medicaid. And every state is in issues with that at this point in time. I'm going to describe you the development of the sickle cell care disease network, and to understand it, you have to understand this slide, which is going to show up, and I'm going to build it from this slide. So pay attention, please. It's the integration of, in a community, independent primary care physicians, in our instance, federally qualified health centers, regional hospitals, and community-based organizations, which I may call SCDA chapters or sickle cell foundations, I'm not sure, the process. And how to integrate that and have it interact with a comprehensive sickle cell center that has both pediatric and adult hematologists who may or may not at different points in time be fully committed to the idea of taking care of persons with sickle cell disease. And those are the realities. But what this is the gross anatomy, if you will, and some of the definitions that, now overlying this is a big cloud. So the thing that controls the interaction between these pieces, these entities, and the interaction in a vertical plane with these entities is in fact a number of things, which one of which I've just mentioned, Medicaid funding, critically important, payer mix, shifting alliances. There are times when a hospital may not gain benefit from being involved, and therefore, or they may do it better in another way, and so they won't participate. They drop in and out. It's an ongoing evolutionary process to build a network of sickle cell care. And then within the university itself, there's people who come and leave, and they're critical players in holding things together. HIPAA has been a major challenge to us, and if we're ever going to collect information, whether it be health services information or basic science information, IRB is an overwhelming mountain to overcome in order to do research and collect information. Particularly if you have people in Montgomery, Alabama, an hour and a half, 2 hours away collecting information on sickle cell patients that they're ready to report out to UAB. I will tell you, I had my fill with, I can easier give a lethal drug to a patient than I can collect a little bit of health information on the person 1 hour away. That's the truth. So these are some of the challenges and the cloud that overshadows us, legal issues as well. Okay, so I'm going to describe to you the evolution of this care network. And it spans nearly 24 years. Prior to 1988, when I first came to UAB in about 1985, we had just opened a sickle cell clinic. Once a month, 4 patients, and we patted them on the head and said, you ought to take penicillin. And that's what it was. That's all there was. There was no continuity of care, no communication with the primary care physician, nothing. just a pat on the head, and you'll see, even on the inpatient, we didn't even take care of the inpatients. So that's the standard of 1988. At that point in time came a big force right here, a community-based organization, the North Central Alabama Sickle Cell Disease Association. Sharon Lewis, who is the executive director, and one incredible force, linked together with myself. And what we were doing then is there were just 3 little pods out there on their own, and there was phone call referral as needed, and inpatient transfer, and that was all the interaction there was. We got the idea first with a community grant that we collected a little information on newborns that were positively screened. We got the idea that, and then subsequently Sharon put me on to the fact that there were maternal child health grants out there for newborn screening follow-up, and I made an application for one and opened a little clinic about an hour and a half, 1 hour and 3/4 north of Birmingham in Huntsville, Alabama. And we learned from that we really did impact a greater number of people, and we worked with them in the community, so if the patient came to us, we actually knew who they were, rather than just being a random referral. So with that beginning, I sat down with Lee Hilliard, who is another important player that developed this network, who was a fellow then, and I said, maybe we could open something that does these outreach clinics in a number of places. And so we formulated the Children and Youth Sickle Network. The concept and objectives of that was to bring comprehensive care to people closer to their families, and so we moved and put together a network of regional clinics where we go out to it every Friday. We're on the road. We go out to those clinics about anywhere from an hour and 15 minutes to an hour and a half away, and we see in some clinics 23 patients in a day. We started those clinics, and we went out there and patted a lot more people on the ability to take their medicine. But we also reviewed their history. We came to know them. We came to know and link with the primary physician in the area. This is a map of Alabama showing the location. We are located in Birmingham, Tuscaloosa, Selma, Montgomery, Opelika, and Huntsville. We established clinics by working with the primary care physicians in the area, by taking them with us in the CBO in the local region. And there are 6 CBOs with which we work that serve these counties by highlighted areas, and their names are over there. And what we did is we went to hospital administration, so we like to open a regional sickle cell clinic. And we got variable degrees of support, but for the biggest part, because it was a community-initiated activity, we were blessed. So we have reached this network of regional clinics that are in these cities. The idea was, and this is getting to be an older slide, but with the CYSN clinics, what we did is we saw patients. This is the frequency of clinics, the sites at which they're located around the state, and then one of those, of course, is in Birmingham. There's a total of about 78 of these clinics per year. We're now up to about 4 clinics a month in Birmingham because we've added an adolescent transition clinic. And what we do is, this is the kind of staffing as this program evolved. A pediatric hematology with or without a fellow, a transcranial doctor or technician, 2 to 3 nurse practitioners who come out of children's and are funded by children's. I convinced them over the years by a variety of funding sources. And a clinic coordinator, and if there are studies going on, a study coordinator goes with us. And the local community, the CBO furnishes a counselor who is the educator, and they educate using a program called Baby Step. And then we train house staff, meet house staff in many of these places and train them even as we see patients. Well, this became a fairly popular thing and shifted the dynamic within this network. And now the regional sickle cell clinic opened up communication between independent pediatric primary care providers, the regional CBO. The primary care providers didn't even know who the CBO was. The hospital didn't know who the CBO was. So it introduced all these people and began an interaction and sharing of information and increased referrals with purpose between the regional clinics and the, we tried our best to keep the primary care provider at the center of things. But I noticed that adults kept doing the same thing. Okay, adults are on the right side of this slide. What have been the impact of this? Well, it's rather remarkable. And I'll just cite some of those. These are listed, but I'll go through them. One is This is a distribution, and this slide is from about 2000, where we had about 600-700 patients who had fluxed through. These clinics were established in about 1994 to 95, and this was about the pivotal year of about 5 years to follow on. This is where they were. Shown in red are the ones where the highest density of patients are, Montgomery and Jefferson County, where we are. And then there's a smattering throughout the state. Some counties have only one sickle cell patient. We ended up seeing patients out of 67 counties, and the locations of the outreach clinics are shown as Huntsville and White and so. This activity, and at the center of these is the clinic site, brought comprehensive sickle cell contact to university hematologists within 60 miles of 95% of our population in 62 counties. Review, and then when the patient was referred and the primary care doctor called, we knew the patient, we knew his diagnosis, we knew something about the problems that he had, and we knew where he was at the time. We communicated with primary care docs through a clinic note, and that was our primary coordination of care tool at that point in time. This distance was decreased cumulatively by about, 2007, 1,387 patients had fluxed through this Children's Youth Sickle Network. And active patients under 19 were 1,000, under 20 years of age were 1,000 total patients. Active population, meaning we'd seen them in the last 2 years, is about 883. So we had a pretty good activity. 80% of the patients were active within this network. You can see that this was when we instituted. We had a change in the slope of growth of our sickle cell population, and then it leveled off, and it has stayed. Currently, our number is about 965 active patients, with probably a cumulative number that have fluxed through of about 1,800 patients altogether. Many of them moving on to adult care with or without the benefit of coordination of their transition. It decreased the time to clinic for newborn screened positively every year. It decreased the time to access to penicillin, simple things, but very important things. Integrating the primary care physician's activity. And that has continued over the years, so that we had a kind of a glitch in 2007. ADPH, the Alabama Department of Public Health, funded a sickle cell coordinator, which is still funded, and that got cut about 20–30% this year. But as you can see, our time to clinic now is about, to comprehensive clinic is about 60 days, and we've been able to sustain that for the last several years. We see all the patients. We see about 90–95% of the patients by 2 to 3 months, and all the patients by 6 months, anymore that come out of newborn screening in the comprehensive center. We instituted a training program for children who have parents who have called Baby Step, and we copyrighted that. It's called the Baby Sickle Training and Education Program. It's a sickle cell specific comprehensive education program, which is aimed to educate patients, parents in home care and health care. Focused on all the problems that you have from 0 to 10 years of age. It's designed to complement the primary care providers' care and education. Ultimately, we did the same thing with primary care providers, as I will show you. It's usually, its objective is to be completed about 3 years. Sometimes it takes 4 and 5, but we get through it. It's about 10 sessions. Most of the longest session is 45 minutes. Most of the sessions are about 20 minutes. There's a pre-test, post-test. We've assessed whether or not people are getting the information and getting the information across. Originally, that was taught by nurses one-on-one. And then we taught the CBO sickle cell counselors how to teach it, so they came to teach and did the education while we saw the patients. And it covers a whole variety of problems that occur. And if somebody wants it, and I'll mention this, we've put together a packet which is on sale at cost, and I'll advertise that a little bit, on sale at cost, if you want to have access to it. And I don't think the cost is overwhelming. I think can't remember exactly, a couple $100. 17 now DVD-based educational programs that do the same thing that nurse or a community-based organization person did based on in the past. And that was an enhancement that came with the further development of that. Impact on mortality. All of a sudden, our sepsis rate, death due to sepsis rate decreased. The number of total deaths decreased. Those 2 that were not sepsis deaths in the early onset of the Children's Youth Sickle Network, homicides. People were not dying of sickle cell disease at that point in time. And since that time, we have had probably throughout this network at most 5 or 6 deaths due to sickle cell disease-related complications. And there have been more killed in automobile accidents and by violence than have been without equal number of that and sickle cell disease. We consistently have about 50 newborns coming in per year, and at that point in time, about 773 patients. It impacted upon the morbidity. At Children's Hospital, we were able to monitor what was happening with admissions and transfers for chest syndrome and tertiary care, and it decreased morbidity, and that's shown here in every area except for elective surgery, which increased morbidity. People were admitted more frequently to fix their gallstones, to deal with their TNAs for obstructive sleep apnea, to deal with the problems of sickle cell disease. And also, I didn't bring it, but it saved in 2000, after 6 years of existence, with about 750 patients active. It saved the Children's Hospital of Alabama $1 million per year in charges. Now you get to gain on that once, so I hired some nurse practitioners. But it saved them $1 million a year in charges. Now they never would let me see costs, and if I have a feeling, I haven't analyzed that aspect as thoroughly. When it comes to introducing a new or advanced approach or a therapy or a new advanced approach, when TCD came along and STOP 2 came along, we integrated that into the Children Use Central Network. For those of you who are familiar, TCD allows us to identify those people who have risk for stroke. It analyzes the rapidity of flow in the blood vessels, increased rapidity above 200 centimeters per second, points to the idea of going on chronic transfusion to prevent the first stroke, primary stroke prevention, as opposed to waiting for strokes to happen and transfusing people through the second, third, fourth stroke. We did our best to do what STOP 2 did, which was try to do TCDs every year. That's what the data says. The best we could do is we could catch people about every year and a half. In any 1 year, we could only patch about 25% of patients. Best year was about 30% of patients. But even given those failures, having done 1,270 TCDs on 3,280 eligible patients, ultimately, we brought TCD to the country and to the city. So this shows, again, our clinics. It shows that it brought TCDs, and it says how many TCDs we did in the different areas. The color code here shows the most rural counties. Here in light yellow, the most the urban populations in bright green, and that's the population densities in the state of Alabama and the southwest side. Population density and how rural it is approximately that of some areas, most of the areas in Wyoming. Not a very high population density, that's the east of the state. So these people don't have a lot of access, but they had access to these TCDs. The network allowed us to bring that to them. What was the impact of that? Well, first of all, let me say that if you lived in a low population density, your likelihood of getting a TCD was equal to that if you lived down the street in Berkeley. So we're very proud of it. And the impact was this. This is a graph of CVAs, the number per year from 1992 up through, and then this was the introduction of TCD. Along here, we lost our TCD tech. We had a little blip. I think this graph speaks for itself. Prior to, we had a 4.5 CVAs per year incidence. After, overall, we had about a 1.5 per CVA, but if persons were compliant, we decreased primary stroke. We had primary stroke prevention drop to about incidence of 0.18 per year. This is what happens if you're non-compliant. Now, non-compliance here means, this is the non-compliant people. It means we could not comply with our own protocol for screening, or the patient didn't come back when we asked them to. And you can't take it personally when somebody strokes if you can't get them back. You can only educate people. You can only educate primary care physicians. You can only teach them and do your best. I say preventative care, you only know when you're not doing it well, or when you're doing it well, when you fail. And that's an example of it. Now, sometimes we fail. Sometimes we miss getting the patient back in. So it's a failure of the system or the patient. It's not one. But for those people who are compliant, except for 2 strokes, In the first year when we were doing PCDs, one of these was stroked 1 month later, 1 month beyond a screening period. So I think we probably decreased the stroke incidence rather dramatically through the network. Network also brought advanced therapies such as hydroxyurea. This shows our hydroxyurea use from the beginning. We initiated in about 1997. Currently we have about 277 persons on hydroxyurea, 29% of the sickle cell population overall. That includes SCs, eligible SCs. And about 40% of our SS population are on hydroxyurea. The availability of that therapy, advanced therapies, both hydroxyurea and chronic transfusion, is the same if you're seen in a Birmingham clinic or in a remote clinic. We're very proud of that. The next step in the evolution of our network was sickle cell treatment demonstration project funding occurring about 2005, 2006, and it brought the following kinds of challenges to this network. We began to step outside of the pediatric only age group. Brought new partners in the form of federally qualified health centers. We had to learn how to work with them. It brought coordinated care. For the first time, instead of the note back to the primary care physician, we actually developed a care plan, which was shared between the primary care physician and the university center and the parent. And we got smart enough to figure out we needed care coordinators, which I'll show you the impact. We developed new community services in the community, services now for adolescents that they have a place to go, at least a small fraction of them if they became adults. We developed community service of transfusion. We developed a community transfusion service for sickle cell disease, which evolved into an adult transfusion service. We developed access to non-hematologic subspecialists. We had a lot of specialists we transfused chronically at the university center, but they didn't have a GYN doc. They didn't have an internal medicine doc. They didn't have a primary care physician. They didn't have neuropsych support. They didn't have dental. And the FQHC brought that opportunity to integrate them in a reverse manner out of the university center into the primary care. We had to develop an enhancement of Baby Step, which I shared with you in the booklet and put it DVD based. And we developed a provider education program, both primarily focused on pediatrics. So got through our sickle cell network overview. We were improving. This is where we were up to about 2005, and the federally qualified health centers came into focus in the community. We began to work with them, and that opened to us adult primary care providers, pediatric primary care providers for about 150, 200 patients that we had identified, and access to subspecialists, not hematologists in this particular instance, because FQHC did not have a hematologist. But it increased the interaction between the community and the university. The federally qualified centers we worked with Health Services Incorporated, centered out, and these color codes are all screwed up. Copied the slide into this and it did something to it. I don't know why. But at any rate, Health Services Incorporated, the grantee they were the grantee in the original sickle cell treatment demonstration project. Burnell Knapp, an outstanding man who runs an outstanding FQHC. And let me tell you, I have learned a lot about FQHCs through this interaction. Originally, we started with 4. There are only 3 up here, so that tells you one thing. All FQHCs are not equal. All FQHCs are not equally well managed. And they cannot supply all of the care to persons with sickle cell disease. That's an erroneous assumption. They're another medical home, another source for medical home for persons with sickle cell disease, but not the only one. So, the Bob Watley Center in Western Alabama and Purple Quality of Life in the Gadsden area, that's where they're centered, furnishes these communities. And as you can imagine, that overlaps pretty well with our network, if you will, our CYSN network. So we began to have a little impact on adults. Sickle cell CBOs in the area were also involved in much the same way they had been. One of the things that we learned is we needed care coordination. So we appointed in each site primary care coordinators who were nurses or nurse practitioners, and tertiary care in the university center, and these people communicated, and then communicated with the docs and kept the flow and the coordination of care from primary to tertiary and from tertiary back to primary and communication open. That was guided by care plans and protocols which were shared, protocols for transfusion, protocols for hydroxyurea, algorithms for hydroxyurea use. This led to, in our measurement, and we were in the pre and the post era, the original sickle cell treatment demonstration projects led to improved quality of life, improved access to hydroxyurea, improved access to transfusion in the community. And those are the primary things. Improvement, nobody understood, the people that we talked to, the patients, never understood what a medical home was. I have to admit, neither did I really understand, although I'm describing to you the support of development of the medical home. This is our care coordination tool. We had them for 0 to 10, 10 to 21, and 21 and above. This is just the front page, the kind of information we go over. Let's try to update it every year if we possibly can. That's a lot to do. It's not too bad. And 100 patients and 1,000 patients is impossible. These are the kind of areas in the 10 to 20-year-old we focused on, including tracking what we did. And the important thing is this tried to delineate, these are the responsibilities of the primary care physician, these are the responsibilities of the hematologist. And by communicating that in a written form, the idea was to try to communicate that to families as to how to seek care. Because many times families get lost into who do you go to, or they don't trust the primary care physician. We've dealt with all those things. And what's going to happen is that will continue to happen unless we empower the primary care physician through a network to allow him to get the right information and to improve his knowledge and his ability to deliver care in his community. I'll talk about that a little later. Here are some of the things that improved access to care. I talked about collaborative plans. We developed a collaborative pediatric transfusion program, established transfusion protocols, and suddenly we were transfusing patients in Montgomery who came for subspecialty care in Birmingham because we had a surgeon, but they didn't. And we also transfused people in Birmingham who went back home and had the surgery looked because they didn't have transfusion capability. And then we also we experienced the other thing, which is pre-surgical transfusion in the community under the same standards that we utilize in the Comprehensive Sickle Cell Center. And surgery in the clinic, and it all worked well. And we've done this many times. So again, it's keeping the family in the community and making sure that they have access, and it saves tons of time for families. Improves your ability to get things done. We developed a collaborative, pilot collaborative hydroxyurea treatment program, which also is called the hydroxyurea co-management program, that established hydroxyurea protocols and algorithms. We furnished a nurse who served as the coordinator for that and kept up with counts and managed people on hydroxyurea. Subspecialist support, other subspecialties we talked about. We developed a primary care provider sickle cell disease education program, improved hematologist. I got my phone was ringing all the time, primary care physicians calling me, or that primary care coordinator calling me and saying, what do we do with this problem? And it was pretty much an ongoing every day. I'd say cell phones improved the success of this incredibly fax won't work. We also had a voicemail where you could leave a voicemail that worked, but we continually talk, and we continue to maintain those relationships now that the funding for MSCD is gone. We had access to adults. By now we had 50 patients, and every age range from 1 to 20 years of age. That's how it adds up to about 1,000 patients. And we had adolescents who needed places to go, but we had no place to send them. It gave us some capacity in the link with primary care physicians. Let's see, the last thing was, we enhanced our baby step program. Provider education program, I'm not going to belabor this because of time, but I will say this. What we did with the provider education program is persons in North Central Alabama, the Central Alabama Sickle Cell Foundation and ourselves put together an education program and took it into primary care offices in the Birmingham area during lunch. Called people lunch, presented it, got critique on it, and kept enhancing it a little bit, and then we converted that into a DVD-based program for education of primary care physicians, pediatric mostly, in the community. We put this into a DVD-based program. Physicians could access that based upon out of a DVD library, or they could access it online here. It was uploaded to that site, the same place as our baby step program was online, so it was interesting. Baby step I mentioned, we rehashed it in accord with the advisory committee's recommendation, switched to the DVDs, created an educational kit. I'm advertising that if you're interested. It was reviewed by PERSA's National Coordinating Center and the Sickle Cell Treatment Demonstration Project Educational Coordinator, put it to appropriate age level, gave it a blessing. SURG, Southeast Regional Genetics Group, has now adopted that as their standard in the Southeast region. It is posted on the children's website. That's an incomplete but you can go to the other one for the provider education, and you'll also find the baby step program there, including the pre-test, post-test, etc. And it was posted then on Jim Ekman's site out of Alabama, as well as the sicklecelldisease.net website. Finally, after using this for about 10, 12 years, we evaluated it, and we learned some stuff that we were surprised at. We learned that we could get the training to people regardless of what variation of sickle cell disease they had. But we learned that the persons who needed it the most, the persons with SS, were the least likely to complete the entire thing. That led us to postulate how we can get it, so we're now investigating putting it in the homes people want it, putting it at the point of care and primary care physician's office, and making it available in hospital admissions, because we think we're missing these people because there's only so many times you go to the doctor. And persons with SS always make those phone calls because families have other demands on their plate. So we think we need to be able to get them to access the education at the point of contact. If that point of contact is their home, so be it. The problem is how to track the progress through the pre-test, post-test. So suddenly we have FQHCs to deal with, and we have relationships to other new providers, and that gulf that used to exist between adult pediatric care began to break down. We began to see how we might go forward. What has happened beyond the landscape from about 2008, 2009 to present? Well, we have developed new partners again, the UAB Adult Sickle Cell Clinic, UAB Montgomery Sickle Cell Program. We've been instrumental, I think, in helping them to evolve this and get it off and going and allow it to interact with primary care physicians. We've enhanced our adult services. We've extended the coordinator and care plan idea to adult patients. We've worked hard in adult provider education. Remember everything we had before was pediatric, right? And we've begun adolescent transition, and now for about a year have been running a hydroxyurea management program. So here's what happened within the network. First of all, this big arrow right here, Sharon Lewis of the North Central Alabama Sickle Cell Disease Association was on the move again. Starting in about 2004, she initiated an effort in Birmingham to raise $1 million to focus on the development of adult sickle cell care, something that was still functioning in the dark ages. Simply referral, we really don't want to see you. You know what I mean. If you have sickle cell disease, if you ever advocated for sickle cell disease, you know what I mean. Okay, so she pressed on and put herself in the center and broke this gulf down between adult and pediatric care. So there you go. And the impact was the development of the adult sickle cell clinic at Kirkland Clinic, now with a social worker, with a dedicated nurse practitioner, and a dedicated doctor. That's huge in Birmingham, because we didn't really have that in Birmingham. I had better organization in Montgomery, Alabama than I did in Birmingham with respect to adult care. The second thing that happened is Baptist Hospital, the largest other group in Montgomery, got in league with UAB Internal Medicine. Now, our relationship was, for years, our CYSA clinic had occurred in Montgomery in the space of the UAB Internal Medicine Department. And as we kept doing this year after year, they became interested. And they began to take on a few of the patients. And then the patients ended up in the hospital, and the hospital said, we need to make this better. We need to keep people out of the hospital if we can. And so they contributed a care coordinator, internal, and a nurse practitioner, internal medicine, created a doctor, and we began to have the possibility of adult care in Birmingham. In Montgomery, those people interacted with individual hematologists in the community, individual adult PCPs, and they didn't take over the patient themselves. They maintained that relationship. They maintained that relationship of trying to keep the patient in the primary care doctor's office. And that, of course, opened up to much more interaction between Birmingham, the adult side, and Montgomery. So what I've described to you then is the evolution then of this network, which I'll draw for you. In this box are all the players. And I've fused them because pretty much the patient is now at the center of this. And there are patients who need advanced tertiary care, who get over here and get lost, and maybe the only time they see the PCP is once a year for the ESPDP screening. So I'll validate the Medicaid so we can keep the report. And unfortunately that happens. But that happens to a small portion of patients. 80–90% of the patients, as I look at now, actually do see their primary care physician. He doesn't always know the needs. He or she doesn't always know everything about sickle cell disease, but we keep hammering on that education thing and trying to. What are some of the impacts of this increase in capacity of these new changes? Well, one is at Children's Hospital, there was a decline in the number of patients who are on chronic transfusion. Around 2004, we had 110, 120 persons who were chronically transfused at Children's Hospital in Birmingham, regardless of where you were from, with a minuscule number of patients transfused in all sites down here. Okay, great. More recently, as this has evolved, we've seen an uptick so that of patients who are pediatric and transfused, 22% of them in this coming year will be done in the community in Montgomery using the same standards that we used in Birmingham. And we monitor those, and we're getting ready to transition the monitoring of those as they evolve to adults, to the adult care, the tertiary care. It also opened the opportunity that we could transfer patients who aged up to UAB, internal medicine in Montgomery, and to the hematologist at UAB. So it decreased the burden on us and allowed us to reutilize some of our resources, focusing more on hydroxyurea. I'm almost done. I'm okay? Yeah. So hydroxyurea co-management. The concept here is, for years, pediatric oncologists have given IM methotrexate for maintenance of persons with ALL treatment for years, interacting with primary care physician. All it takes is a count, and a nurse gives you the call. And you say, yeah, the count's good, give it. No, the counts are bad, don't give it. Same thing with hydroxyurea co-management. So here's what we've worked out. We cannot see all the patients. We are reached our maximum. I can't hire enough people to follow enough people who are hydroxyurea, even though we have a more lax follow-up program than most people in the country. And I would make the comment that people in the country need to stop and think about what they're trying to accomplish with hydroxyurea. It doesn't make any difference to say it's a guideline or a requirement to give a drug unless you can deliver it. The drug won't work if you can't get it to the patient. And so we're trying to work out a system whereby we can give hydroxyurea and monitor it carefully. PCP agrees to have his patient's count monitored on hydroxyurea. He agrees to participate, follows the shared hydroxyurea protocol and algorithm to help track where the patient is in the process. We furnish a hydroxyurea coordinator. Coordinator communicates with the office and the family, ensures accounts are obtained with facts for UAB. Coordinator reviews and discusses the dose adjustments with the hematologist, and then orders hydroxyurea, communicates just doesn't hold it to the PCP. That's not the same thing as primary care doctors putting people on hydroxyurea. It's the first step towards that. Go. Currently, we have about 80 patients who are in hydroxyurea co-management. We've been at this for about a year. So far, we've seen no difference in our holds, toxicity, dose, or effectiveness. 80% of those people are people who live outside Birmingham. Unfortunately, the people who are local become dependent upon us. As a matter of fact, I will say to you, I think there's a direct proportion to the distance away from us as to how much of a medical home we really have. If the patient is too close by, the primary care physician throws up his hand, abandons the patient, and and lets him go to the tertiary center and he doesn't get any primary care, he doesn't get any coordination, it's a mess. We need to give that up. University hematologist, in my opinion. We need to understand, we need to facilitate the primary care physician, because hydroxyurea is a standard of care for all patients with sickle cell disease. You will not be able to sustain that in a safe manner. And I really don't care what the current guidelines say from the HLGI, they're going to come out. You can recommend hydroxyurea, but it doesn't make any difference if you can't deliver it. So, we also developed, so here are the things that I've learned. Lessons learned. The probability of building and maintaining a medical home for sickle cell disease patients is directly proportional to the PCP's knowledge of sickle cell disease, ready access to and communication with a hematologist, stable and long-term relationship with the patient. It's a chronic disease, and you can't spend your time in the emergency room and expect that you're going to get better. They don't fix you in the emergency room. Endorsement of the PCP by the hematologist. Whenever we began work with FQHCs, there were some of those FQHCs that had high turnover of their doctors, and some of our subspecialists did not respect the physicians in the FQHCs. It's a cultural issue. We went to Washington, had all this stuff about cultural issues with Hispanics and persons from Africa and things like that. There's a cultural issue within the medical community, which is a culture of doctors. And you can either call the person inadequate, or you can bring him to the standard to become adequate. But you can't just sit there. You have to endorse the primary care physician, and to do that, you may have to bring up his level of function. Access to advanced therapies, access to unique type. We only have one community outside of Birmingham that can deliver a TCD at this point in time. To the patient and parents' knowledge of sickle cell disease, the willingness to see the PCP, the willingness to accept advanced therapy in the community, and not think they've got to have a hematologist to do that. And the distance from the hematologist. This is pointing to the point that if you live in Birmingham, it's much more likely that you will abandon your primary care physician and think you're getting the best care of the hematologist. Maybe you are, maybe you're not. To the hematologist, humility. You can't be too proud as a hematologist. You've got to work with people. To the willingness to educate and communicate. And indirectly proportional to the severity of disease and the complexity of the PCC's fear of the therapy. Everybody's scared to death of hydroxyurea, but we've been given that's correct, say, the primary care doctor's offices for 15 years. That's chemotherapy too. If you want to use the word chemotherapy to scare you away, that's silly. This is chemotherapy ultra-light. This is chemotherapy hydroxyurea. It's directly proportional to stable Medicaid funding and extramural support of hematologists. These are some of the sources of grants that we have had, pieces and bits over the years that we've held this together. We've done clinical trial studies, and in so doing, we brought state-of-the-art opportunities for those people who want to participate. If they don't want to participate, it's fine. But it enhanced our ability to do the most modern and most current thing and bring it to you in a real-time fashion. And thanks ever so much to Sharon Lewis and Lee Hood. Thank you very much.